See, the term oncology refers to nothing but your tumor. Okay. So in nowadays, most of the clinical trials are conducted in your oncology trials. Okay. But you have to understand the things like what are the different, see, oncology is one of the major disease in the current in the world, right? So there are different types of cancers like pancreatic cancer, prostate cancer, gastric cancer, colon cancers, okay, breast cancer, different types of cancers are there, even blood cancer, different types of cancers, okay. But you have to understand that there are different. So now see, for example, coming to blood cancer, we call it as leukemia, okay, blood cancer. Coming to lung cancer or liver cancer, we call this as a solid cancers. Okay, so we are considered two types of tumors. Okay, solid tumor, nothing but solid cancer, nothing but solid tumor. Another one is liquid tumor. Okay, solid tumor and liquid tumor. So we will discuss more on this solid tumors, okay? Because liquid tumors, it's very rare. It's a leukemia. That's basically we call it as a blood cancer, okay? It's very rare. But most of the cancers are solid tumors. We'll discuss more on the solid tumors, okay? So patients who are suffering from, there are different, so patients who are suffering from, patients who are suffering from solid tumors, okay? Solid tumor, basically solid cancers. Okay, there are different ways to evaluate. See, what happens is patients who are suffering from solid tumors, they have different types of cancer. For example, let's take a lung cancer. Okay, see, you have to make understand that lung cancer means the patient will not have only cancer in the lungs. Okay, the origin of the cancer is lungs. Okay, if you talk about liver cancer, the cancer is not liver. Okay, the cancer can be spread to other parts of the body. Okay, but the primary origin of the cancer is liver. The same way, so if you go with the any type of cancer, okay, it's not like a lung cancer means the cancer will be only on lungs, liver means that the cancer will be only on liver, stomach means it's only stomach, not liver. Okay, the origin of the tumor will be stomach or liver or lungs. Okay, but it will get spread to different types of different parts of the body. Okay, next to patients who are suffering from solid tumors. Okay, so what happens now if you take a patient, he's suffering from solid tumor, for example lung cancer. Okay, now let me take for example. Okay, so so this is a normal structure of human body, just okay, just for you to understand. Okay, just the concepts. Okay, you have to understand the concept, how it happens. Okay, this is a normal structure of human body. Okay, so what happens is, now what exactly happens is, when the patient was, see it, now how the patient comes to know, how the comes to know the patient is suffering from tumor. Basically, see, this is a patient. Okay, even how you come to know the patient is suffering from tumor. Okay, there are different methods called PET scan. Please note down. Okay, PET scan. Okay, PET scan. Okay, next one is FDG PET scan. This scans are very important. It will come later on. Okay, FDG PET scan. Okay, another one is MRI scan. Okay, MRI scan, I will tell you why. Okay, MRI scan, there is also called as contrast MRI scan. Okay, contrast, CONTRAST, contrast MRI scan. Okay, even X-ray. Okay, X-ray. Okay, even CT. Okay, so PET scan. FDG stands for fluorodeoxyglucose. Okay, if you want, you can Google later on. Fluorodeoxyglucose PET scan, MRI scan, contrast MRI scan, X-ray scan, and CT scan. Okay, CT, you know, CT scan, computer tomography. Okay, so these are the different ways when they perform scanning on the human body. Okay, okay. So for example, the patient, for example, in terms of lung cancer, okay, there are two different lungs. Okay, here, okay, two different lungs. Now, in terms of lung cancer, what happens? The patient will be, so the patient comes to the hospital with symptoms. Let's talk in a non-clinical. The patient suffering from severe coughs. Okay, so the doctor suggests to go with any of this scan. Okay, now when they go with the MRI scan, no, MRI scan, it will not tell that this is a tumor. In the MRI scan, it will, if it is a MRI film, no, Okay, it will just say that there is a something, one type of lesion like that. Okay, but your PET scan or FDG PET scan will generally confirms whether this is a tumor or not. Okay, PET scan or FDG PET scan. So this PET scan, FDG PET scan will confirm whether it's a tumor or not. Okay, so again I'm saying these are the different scans to identify the tumor, but the most efficient method is the PET scan or FDG PET scan. These scans will evaluate whether the patient is suffering, whether the patient is having the tumor or not. Now, how these PET scans are performed? Okay, the PET scan or FDG PET scan is performed the whole body. So assume the patient is suffering from lung cancer. It's not like, again I'm saying, it's not like the cancers. Okay, so I'm just drawing the lungs here. Okay, it's not like it's not like the tumors will only present in the lungs. Okay, it's not like see, the tumors are nothing but the lesions. Okay, the lesions are not, it's not like the tumors are present in the lungs. Okay, this is one type of tumor which was identified. Okay, lesion we call it as. Okay, it's not like it's not only in the lungs. When the PET scan or MD PET scan is performed the whole body, seems like there are 5 tumors identified on the lungs. On the right lung, two tumors. On the left lung, 3 tumors. Along with that, in the liver, there was 2 tumors has been identified again. So this is the liver. Okay, okay. In the stomach, okay, in the stomach, there is 1 tumor has been identified. Okay. Now, so and in the kidneys, in the kidney region, so there is I'm just writing kidney here. Okay, in the kidney region, 2 tumors has been identified. So that means why we call this a lung cancer patient? Because the tumor got originated in the lungs, and slowly through blood the tumor got transferred to other parts of the body. We call this as a metastasis. Okay, metastasis. Okay, metastatic tumor is a metastatic. Okay, metastatic tumor is nothing but the tumor spreads to all the parts of the body. Okay, now these are the methods to evaluate the tumors. Okay, the investigator is not going to identify the tumors manually. These are the methods they will perform. Okay, they will identify the what are the different tumors has been identified in the body. Okay, now let's think practically. Now let's go practical. So what happens now? What are things we have identified? So we have identified in the lungs region. Okay, there are in the right lung 2 tumors, in the left lung 3 tumors. Okay, now I'm just writing individually. This is the liver. In the liver, 2 tumors. Okay, so this is the stomach. This is the stomach, 1 tumor. In the kidney, I told, right, there are 1 tumor here, 1 tumor here. Okay, maybe in the pancreas also there is 1 tumor. Okay, total how many lesions you have identified? 1, 2, 3, 4, 5, 6. Okay, 7, 8, 9, 10, 11. Total 11 lesions has been identified. Okay, okay. Apart from this, in other parts of the body, maybe in the lungs also, there is small like this, small tumors are there, small, very small. Okay, which are not easy to measure. This type of tumors has been identified, very small, like this, very minute. You can see that minute. I'm just talking minute. Okay, but we will not focus on this small size of tumors. Okay, now what happens? Just think logically. This patient, this is the body FDG PET scan of 101 patient. Okay, so when you see now, if you understand this concept, no, even I challenge you that you can read the FDG PET scan also. Okay, if you in our relatives or somewhere friends, if they have the FDG PET scan, you can easily understand the PET scan. Okay, now if you see, these are different tumors. It was identified different. This is about the 101 patient I'm talking about. Okay, total many tumors has been identified. Now just think logically. If the treatment is given to this patient, that is anti-cancer drug. Okay, if an anti-cancer drug is given to this patient. Okay, now again FDG PET scan or PET scan is performed. Okay, so after giving the anti-cancer drug will be given certain period of time, like 8 weeks or 4 weeks. Okay, they will give like at least 4 weeks of treatment. After 4 weeks, again they will do the FDG PET scan. Again they will assess what is the size of these tumors. Okay, these are the lungs, right? This is lungs. Okay, this is your liver. Okay, this is your kidneys. Okay, they will reassess and they will confirm. So this, see, now these scans are nothing but related to your screening. Okay, in the screening, I mean to say. Okay, these are related to screening. Again, after giving treatment for 4 weeks, again they will perform the PET scan for these patients. FDG PET scan, PET scan. Then they will see That means at week 4, we target at week 4, for example, after giving treatment for 4 weeks, at week 4, okay, they will again perform the FDG and PET scan for those patients. They will see whether the size of this, the measurement, the size of this, right? Can you see the size? Is it right? The size, it's something like, assume this is a 8 mm, like that, 8 mm diameter, like that, okay? The size of these tumors has been reduced or increased, they will see. But the challenging is there are almost 12, 13 tumors are there, okay? It's very difficult for them to assess. You're getting my point? It's very difficult to, because a lot of tumors are there, right? A lot of tumors. So a lot of tumors are there. It's very difficult for the investigator radius to assess whether the size of the each tumor has been reduced or increased, because total 13 tumors are there. It's very difficult, right? That's why it's very difficult whether the patient is showing the response to the treatment or not. It's very difficult to assess. You're getting my point? It's very, not to, now these all these 12 tumors, okay, all these 12, each of these tumors, tumor size will be measured at screening and also at week 4. That is after treatment, after 4 weeks of treatment. Now some tumor, it's very difficult for them to assess whether, for example, what is the size of the tumor at screening. For example, 12 mm is there. Now at treatment at week 4, what was there? It is 10 mm. Okay, only 2 mm is reduced. It's very difficult to assess all these tumors. That's why, that means it's very difficult to evaluate the response, whether the patient is showing the response to the treatment or not. It's very, very difficult. That's why this is very false statement. We are not going to evaluate in this way. So that's why, what is the, so patients who, so now what is the method we are going to do? So there is a guidance called RECIST guide. Can anyone know what do you mean by RECIST? Did they talk about RECIST? Response evaluation
criteria in solid tumor.
Yes, criteria in solid tumors. Okay, in solid tumors. This is for, see response. See the name, response evaluation criteria in solid tumors. That means patients who are suffering from the solid tumors. For them, that means especially for lung cancer, liver cancer, pancreatic cancer, prostate cancer, breast cancer, uterus cancer, in this type of cancers, we followed the RECIST criteria, response evaluation criteria in solid tumor. That means patients who are suffering from this type of cancer, which I have mentioned earlier, for them, the RECIST has given some guidelines how to evaluate the tumors. Okay. Now, in terms of, we call it as INRC 1. We call it as International Neuroblastoma Response Criteria. This is for, especially for brain cancer. Okay. International Neuroblastoma Response Criteria. This is for brain cancer. Okay. Next one is, okay, PCWG. Okay. PCWG. Okay. Prostate Cancer Trials Working Group. This is specially for the prostate cancer. You getting my point? Okay. That means for every type of disease, they have some guidelines. Prostate, they have some the piece. If you want to conduct clinical and prostate cancer patient, no, follow the rules that was given by the PCWG. If you want to conduct a trial on the brain cancer patient, follow the rules of the INRC. Okay, that's what. Next, RANO. Apart from this, okay, I don't want to stretch more. I'll take my last one. Okay, IMWG. Okay, International Myeloma Working Group. This is for multiple myeloma. Basically, we call it as a bone marrow cancer. Okay, International Myeloma Working Group, which we call it as a bone marrow cancer. So these are the different guidelines. Like this, we have almost 30-40 guidelines we have. Okay, but most the famous one is the RECIST one and IMWG. Okay, or for example, the patient suffering from the multiple myeloma. No? So if they want to conduct cancer on the multiple myeloma, we use IMWG rules. Okay, these there is separate guidance documents was given in this IMWG. Okay, see, basically these are nothing but RECIST, INRC, PCWG, IMWG. Basically called as a, these are some set of documents. Okay, so that document will tell you that how to evaluate the response in the patient suffering from different types of cancers. Okay, so we will talk more about RECIST because RECIST is one of the major criteria which used for the solid. Because nowadays most of the cancers, solid cancers. So RECIST is one of the major one. Okay. Now, what was the guidance given by the RECIST? So what is the guidance given by the RECIST? So RECIST has divided the different guidelines. Okay. So now again we have discussed earlier, right? So what we have discussed, these are the lungs. Okay, these are the lungs. We have 2 tumors in the right lung, 3 tumors in the left lung, and this is the liver. We have 2 tumors in the liver. In the stomach, 1 tumor. Okay, just remind for yourself. Okay, and for kidney we have 1 tumor like that. Okay, now what? And for example, in pancreas again 2 tumors. Just assume. Okay, now what what this is for basically lung cancer. Okay, I don't, even it is a lung cancer, when you do the FDG PET scan, the whole body, when we do the PET scan, these type of different tumors we have identified. So what that RECIST has given, instead of identifying all these tumors, okay, just so you have identified all these tumors, just mark only 5 tumors because it's a target tumors. So what is the guidance for RECIST? As per please note down, as per the RECIST guidelines, only 5 target lesions has to be selected. You have to target only 5. Among these, please target only 5. Okay. So RECIST has given which of the 5 targets is up to the decision by the investigator radiologist. Only 5 target lesions you have to target. Okay. Now per organ only 2 is allowed. Again, I'm saying per organ. So in the lungs we have 5, right? We can select this one. Okay. I will select this. I will mark them as a red. Okay. We can select this one. Okay, we can select this one. Now per organ only 2, 1 and 2. This is lungs, right? This is lungs only. So as per RECIST guidelines, only 5 target lesions you have to select. Okay, from the entire body, and 2 per organ. Now this is what? Liver, right? Yeah. For liver, we will select 1. Let's select 1. Okay. So this is first, we have identified this is 1, 2, and this is 3. Okay. And in kidney, let's take 1. Okay, 4. And in pancreas, let's take 5. This is total 5 lesions we have identified. We call this as a target lesions. This is why you are selecting 5 means it's very difficult to select all this tour and see whether the patient is showing response. Just select only target 5. The selection will is not decided by you. It's completely dependent upon your radiologist. Okay. So in our data, we are going to track these 5 lesions. Okay. Now how you're going to have. So HDMIG has given TU domain. In the TU domain, so we have subj ID. Okay, we have TU. I'm not going to write TU test code. Okay, I'm just writing TU test. Okay, TU or RES. Okay, and visit. This is visit, and this is TU. Oh, one of the most important point I forgot. Okay, TU link ID, you know, all these things I think explained. Next TU method, that's it, we don't want to discuss more. Okay, so subj ID 101, how many lesions we have identified now till now? Anyone? 5 target lesions, right? We have identified, right? That's what 1, 2,
Yes, sir.
3, 4, 5. 5 target lesions was taken. So what is the lesions we have identified? So TU test will be tumor target. No, test is tumor identification. Yeah. Tumor, what tumor you have identified? Tumor identification, basically. What tumor basically you have identified for this patient? Okay. So now TURS is what you have identified?
Targets.
Everything you will have your targets. Okay. Now link ID is to identify the tumor, because he has to identify the tumor, right? Radiologist after giving drug for long period of time, if you want to do again PET scan, no, he has to identify that. So in the right lung, the above one, the first one is the first one. In the left lung, the first one is the second one. So he has to make identification, right? That's what we give link ID T01. Okay. T0 to 20345. Okay. Now, where did you identify this? In which visit you have identified? Screening. Right?
Screening.
Because the patient comes to the assessment. Okay. What is the method? Let's assume FDG PET scan. Okay, maybe PET scan. Go with the PET scan. Let's go to the PET scan. Okay, PET, we can have PET, MRI, different scans. Okay, PET scan. Now, what is the TU location? Now, the first two comes to lungs, right?
Lungs.
Okay, lung. Now, third one, let's go to liver. Okay, maybe kidney we have kept, right? Something, what is kidney and pancreas. So this is your TU domain. So what does the TU domain, what exactly your TU domain captures? TU domain basically captures the identification of the tumors. Okay, what tumors you have identified. Okay, what tumors you have identified. Whether so you have identified what tumors? You have identified 5 target tumors. And what is the method? By using PET scan method. And so what is the link ID for each tumor? You identify tumor, you have given the link ID and different locations. This is the TU domain. Now we call these target tumors. We call, okay, note down. Okay, please note down. Target tumors are considered as measurable lesions. Okay, because we are going to measure these lesions. So we call it as a measurable lesion. Target tumor. Basically, target tumors are we call it as a measurable lesions. Now, sir, what about the other tumors? Okay, see, the other tumors are something like I don't know, there could be some small or maybe these tumors. Okay, so these tumors we call them as a non-target tumors. Now, target we have selected 5, sir, but what about non-target? Not more than 3. Please note down. For non-target tumors, not more than 3. Because we are not going to target those tumors. Okay. So, for example, non-target, let's keep this as 1. Okay. Let's keep this as 2, and let's keep this as 3. Okay. And see here I'm given very big structure, but let me keep very small. Okay, non-target tumor basically this is basically very, very small. Okay, this will be very small. Okay, so we are not going to target, but we are only going to take only 3 non-target tumors. For target, not more than 5. For non-target, not more than 3. Okay, now we have identified how many non-target tumors?
3.
Right. So we'll keep NT01 non-target. Okay, non-T01. NT02, NT03. Now, tumor test code will be tumor identification. What did you identify?
Non-target.
Okay, so non-target lesions you identified. So now, which is same screening visit and in the PET scan method. Now, maybe this is okay. In the second tumor, we have given where in kidney we have given right in stomach. Okay, let's keep it as a stomach. And the third tumor we have given somewhere in maybe, let's keep maybe kidney. Okay, it's not a problem. Okay, kidney. And again, I'm saying these non-target tumors we basically call as non-measurable lesions. Target tumors are considered as measurable lesions, and non-target. I'll tell you why these are measurable. Non-target, okay, tumors are considered as non-measurable lesions. Okay, because I will tell you why they are non-measurable lesions. Okay. Next, what are the what say which lesion can be considered as target? See, it's not rightfully okay. This is 1, this is 2, this is 3. Not like that. Okay, there are some guidelines. The RECIST has given, right? The tumor. Okay, the tumor. But as per the target lesion, what is the guidelines? Target lesion, tumor size. Okay, tumor size should be greater than equal to 10 mm by CT. Okay, but let's keep it. No, I don't want to like this. Okay, should be greater than equal to 10 mm. Okay, so when they perform the CT or PET scan, no, so the tumor size should be greater than 10 mm. Then only he can consider this as a target lesions. Okay, so got everyone till here? Everyone is clear?
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Let's there are a lot of rules for target lesion. I don't want to confuse that. Okay, non-target. So coming to non-target lesions, the size, okay, basically we are not going to identify the size of the non-target tumors. Basically, the tumor size is what? Less than, right? The tumor size less than 10 mm. Okay, the tumor size less than 10 mm we consider as a non-target lesions. Okay, basically small lesions. Okay, small lesions are considered as non-target lesions. Small lesions, basically. Okay, non-target lesions. Okay, small lesions are considered as a non-target lesion. And what is the criteria for this? Maximum how many lesions? 5 lesions.
5.
5.
And
2 from
2
each.
per organ.
2 per
and
organ.
not more than
More than
2 per organ.
Organ.
Okay. Now, how this target tumors has been identified? Identified using
RECIST criteria.
RECIST criteria.
identify using RECIST criteria. So identify by using T01 to T05. Okay. Now for this, identified
T01 and T01
T01 to
NT03.
okay. So this is what we call it as a target and non-target lesion. Okay. Now this target lesion we also call it as what? We also call them as a measurable lesions. Okay. Measurable. So all. So let's keep it as okay. Measurable lesions. Okay. We call this as a non-measurable lesions. Okay. Basically, we don't do many measurement. I'll tell you what is non-measurable. Okay. Measurable lesions. Okay. Like this. So NT non-measurable non-target lesion like that. Okay. Now, so how we are going to consider? Now let's make a simple diagram. Let's make a simple diagrams. So how lesions? Okay. Lesions are classified into 2 types. Okay. Okay. Let's give research. So what is this? Lesions are 2 types. Okay. Measurable lesions. Another one is non-measurable lesions. Okay. Okay. So lesions are 2 types: measurable lesions and non-measurable lesions. So we'll keep like this. Okay. Now, measurable lesions can be again. Let's keep like this. Okay. Target lesions. Okay. So your lesions can go to your target lesions. Okay. Basically. Okay. Your non-measurable lesions can go to where? Your non-target lesions. Basically. Okay. Basically. Okay. So this is a basic rule. Okay. So lesions are 2 types: measurable lesions and non-measurable lesions. Okay. Measurable lesions go to consider target lesions, but sometimes your measurable lesions can also go into your non-target lesions. Why? Because no. See, as I told no. For example, let's keep this as a T1. Okay. This is they can measure easily something like 10 mm like that. Okay. Let's keep this as a T2. This as T3. This as T4. Maybe kidney. This as T5. Can't you measure these other lesions to be open? Can't you measure? See, these lesions you can measure. That means you can measure the diameter of the tumor. So measurements are the but you can measure the diameter of this tumor. Something like this diameter of this tumor is 12 mm. This is something like 14 mm. This is like 18 mm. This is 24 mm, 22 mm. So it means if these 5 see, basically I mean to say that you can also measure this lesion also. Can you measure? Can't you measure this looking at the size? By using PET scan, you can measure. But among these measurable lesions, 5 will go to target. You are measurable. Apart from, assume that there are some small lesions. These are non-measurable lesions. I mean to say that if there are the tumors are very large size, no, among these 5 will be selected, okay, which are measurable. The other tumors are also measurable. You can also measure the size of this. You can also measure the size of this. But there is a possibility these you can move to non-target. You're getting my point? So measurable is the, but see, for example, this I cannot measure. This I cannot measure. Apart from this big tumors I can all measure. Okay. How many measurable tumors are there? 1, 2, 3, 4, 5. It is there. Okay. 6, 7, 8, 9, 10, 11, 12. Oh, I cannot measure this. It's very small. Okay. 11 measurable lesions are there. But among these 5 will go to target. The remaining measurable can also go to non-target. It's completely depend upon your radiologist. Got my point?
Yes.
Right. Okay. Next, there is, so we discussed about target lesion, non-target lesion. Next one is new lesion. Okay. So what do you mean by new lesion? New lesions are nothing but lesions which are not identified.
During the
Lesions
screening.
which are not identified at a screening visit, but was identified during treatment. Okay. So that means at the basic screening level, those lesions are again was not identified. Okay. The lesion which was not identified screening visit, but was identified during treatment. Okay. That means at the screening level, that means what basic new lesion means? The lesions which was newly formed, which was not present in the screening. Okay. So looking at this, assume that after treatment for 4 weeks. Okay. At week 4, again when they do PET or FDG scan, they identified the another tumor here. So they will consider this as a new lesion. Now you may ask, sir, is this new lesion is a target, non-target? This is not target or not. This is a new lesion. They are not going to divide that into target, non-target. Okay. Now what we are going to do is 101 patient. Okay. So they have identified new lesion at week 4. Okay. New 0. So new 01. Okay. So the tumor identification. Now what they identify? They identify the new lesion. Okay. Identification new lesion. Okay. Now they are not identified the screening, right? After giving, so I told, right, for in the oncology trials, generally the assessments will be performed every 4 weeks. Okay. Maybe at week 4. At week 4, they have identified, maybe by the same PET scan. It was identified which one? In the lung. Right. So these, it was not identified in the screening because at the screening level, only 5 target and 3 non-target was identified. But after giving treatment, the new lesion was found. There is a chance, right? There is a chance of forming, right? Because the patient, the drug is not showing very good response to treatment. So there is a chance a new lesion can be identified. Okay. Now, just think logically. At week 4, at a screening, we have identified 5 target tumors and 3 non-target tumors. Are we going to provide the status of the tumor at week 4 also? No, we are not going to provide the status of this tumor at week 4. Okay. In the week, so in the moving forward in TU domain, you will only have the records when there is a new lesion is formed. Okay. So you have identified the 5 target and 3 non-target at the screening visit, but at week 4, you are not going to provide the status of these tumors. Okay. So because you are saying that I have identified 5 target, 3 non-target. But at moving forward at week 4, okay, at moving forward at week 4, okay, at moving forward week 4, you're not going to talk about these identified target, non-target, but you are going to talk about these tumors when there is a split or merging happen. Okay, so during treatment, please note down, during treatment, there is a possibility your tumor can merge or split. Okay, merge or split. Now let's talk about 101, 10. Okay, for the same subject, just let's talk about this, about these two subjects. Okay, now assume that T04. So where did we identify this T04? Somewhere, which where? Yeah, we have identified the T04 here. Okay, assume this after at week 8, somewhere like at week 8, okay, at week 8 or week 12, this tumor has been split into two parts. Okay, split means, so assume this is a tumor, split into two parts. Okay, so that means like this, like this. Now this is not there here. Okay, in this place. Okay, in this I'm writing here. Okay, in this place now it has been split into two parts like this. So which tumor we have split?
T4.
T0,
T4.
T04.1.0, yeah, T04.2, basically, which has been splitted. Now we our TU test called what? Tumor.
Tumor split.
We call it as a tumor split. Which tumor has been splitted? Target tumor.
T0. Target. Okay.
The target tumor has been splitted. Okay. So now it is somewhere like at week 12 I will keep. Okay. At week 12, not week 8. At week 12. Okay. The tumor has been splitted. Now, so maybe at the same, so what we write T4. Okay. Okay. Now, some after later on, maybe at T5, let's talk about T5. Where is T5? Yeah, in the kidney. T5 is in somewhere. Okay, in pancreas. Okay, as in this is T5. Okay, pancreas. T5 is where? T5 is in pancreas. Okay. 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 Let's talk about T1, T2 because next is tumor merge. The T1 and T2, which is present there. So here it is lung. Okay. We don't keep. Okay. Let's assume. Okay. This is your. Just for your assumption, this is your right lung and left lung. Assume you have identified T tumors. You kept the T1 here. Okay. This is you have kept it as T2 here. Okay. So this is T1. This is T2. So at week 16, somewhere like these two tumors has been merged together. Okay. So basically, I'm writing again here. Okay. Which happens like this after merging. So now what is happening? So it will be T01 plus T02. Now what is happened? Tumor merge. Okay, which has been measured? Target tumor has been merged at week maybe at week 16. Okay, this has been merged. Okay, so PET scan, it is in the lungs. So that is what your TU domain. Okay, so in the TU domain, we identify the target tumors, we identify the non-target, we identify the new tumors. Okay, so for example, at week 24, you may assume Karthik at week 24, another new tumor was identified. Okay, I'll just see. I'm going to do another new tumor. Keep it as new 02, new lesion at week 24. Okay, maybe in the kidney region, something. Okay, just for your understanding, kidney region. Like that. Okay, so how many new lesions we are going to identify? The same we are going to show moving forward. Okay, this is what clear everyone till here, right?
Yes, sir.
Yes, sir.
So we will not stretch more onto this. This is T domain. So what we'll do is now we will go to TR domain.
Sir, excuse me, sir. Is the line H38, that box, is that a non-target lesion?
Which one?
Down. H37.
H37.
This box. The measurable lesions, right?
See, measurable is considered as a target. This one, right?
Next one.
Yeah, this is a non-measurable is non-target, is a measurable lesion. Yeah. Oh, sorry, it's a non-target. Sorry.
Non-target, right? Okay.
Yeah. Thank you. Yeah. Non-target. So now we have identified the target, non-target. Now next, let's go to TR domain. So we call it as what is the TR domain full form?
Tumor response.
Tumor results. Okay. Now simple. The difference is TU is a tumor identification. Okay. TU is a tumor identification. Please, these domains will come under findings. Okay. All these three domains, TU, TM, RS, they will come under findings. Tumor identification. You have identified the tumors by using different PET scan or FDG or different scans. Okay. In the TR, you are going to perform. So in this domain, you are going to perform qualitative and quantitative analysis. Okay. Okay. qualitative and quantitative will discuss more of this. Okay, tumor, basically this is nothing but tumor results, where we are going to capture the qualitative and quantitative analysis of the tumor. Okay, so what are the basically the tumors identified in the TU domain will be, so in this domain you are going to perform quantitative analysis of the tumors. Okay, of the tumors identified in TU domain. Okay, now let's just take this copy of this. Okay, let's paste here simply. So now this is TR link ID, TR test. Okay, TR ORES. Okay, visit. Method is not required here, location is not required here. Okay, now TR ORES, TR OR RES units. Okay, let's see. So total 5 tumors you have identified. Now for each identified, so what are the tumor that you have identified in the TU domain? You are going to provide the diameter. For example, 22 mm here. Okay, 16, 15 mm. Okay, this is 12 mm. Just as identify, just assume. Okay, 18 mm, 30. Okay, 34 mm. Very big tumor. Okay. Now for non-target, so this is called quantitative analysis, because we are providing the quantity, the size, the diameter of the each tumor. Basically, here TRS is not tumor identification. Okay, it is sum of diameter. Sum of diameter. So for the 5 tumors, you have done the diameter of the tumor. Okay, tumor measurement. Okay, so where you got the diameter of the each tumor, which is in the mm. Okay, it's not in centimeters. Tumors are always measured in the millimeters. Okay, now for the non-target tumor, okay, we are going to present tumor status. We are not going to do the quantitative analysis. Tumor status. Okay, so what is the tumor status here? Just present. Okay, because in the screening you have identified the right. Now what did you identify from this? 5 target tumors you have identified in the TU domain. For that you are going to do the sum of diameter for those tumors, and for the non-target tumors you are not going to do. Did you do any quantitative analysis? You have performed the qualitative analysis here. Okay, you just showed the which tumor is present, which tumor is absent. That's, you did not do any type of non-quantitative. You did not perform any type of analysis here. Okay, basically you just done only quality. So for non-target tumors we always do qualitative analysis. Okay, for target tumors we always do quantitative analysis. Okay, now for this we are going to insert a new record. So 101 patient. Okay, now sum of all diameters, right? Sum of all diameters of the tumor of the target tumor, basically. Okay, so the test can be anything, don't get confused. Okay, basically if you do sum of this diameter, no, what you got? 101. So 101, which is mm. Okay, so basically this is sum of all the diameters, sum of all diameters. Okay, basically the sum of all the diameters at the screening level. Okay, now for this the link ID will not be there because you have combined all these tumors. Okay, further if you want you can insert TR GRP ID, group ID. Okay, you can say this as a target like that. Okay, so best you can just identify based upon the target. Okay, because for this link ID will not be there, right? So you can just say that okay, all these records belongs to target like that. Now for non-target tumor, you are not going to perform any qualitative quantitative analysis. You just perform the qualitative analysis for this. Okay, you're just showing that these tumors has been performed. These tumors has been assessed. Just that's it. Okay, now we are not going to talk about split tumor everything. Now we are going to go with the new tumor which was identified at the week 4. Okay, so are we going to perform qualitative or quantitative analysis on the newly identified tumor? Anyone?
Yes.
Quantitative.
Getting
Sorry,
Quantitative analysis.
Quantity.
No. See, we already identify the time the tumor here, right? We just identified the what is the tumor that we have, whether it is a new tumor or target tumor or non-target tumor. We just identified. Okay. So as per the RECIST criteria, we are not going to perform any type of quantitative analysis on the tumor. Okay, for the new tumor, you're not going to identify, you're not going to perform any type of quantitative analysis. So you just keep this. Let me see what I used to call. So as per the RECIST criteria, maybe as per the other criteria, okay, INRC are different criteria. Maybe they could have done, but as per the INR's RECIST criteria, we are not going to perform any type of quantitative analysis for the new lesions. Okay, so we just keep the diameter tumor status state. Give me a second. Okay. New lesion. Result what? Did we identify new lesion? Yes. At which visit?
Week 4.
Okay. We just provide that there is new lesion was identified week 4. That's it. Okay. Now at week 4. Now this is done. Now what we'll do is we will replicate the same type data and keep for the next set. Okay. For the next set here, it's come from here. Okay. Now this is for which visit? Let's keep at week 4. Okay. Because see what we see, we have identified the tumors at a screening. Now, you know, right, in the oncology, the patient will take will undergo assessments. Okay. So what happened till here? The screening was done. Okay. For example, till here the screening was done. In the screening, for all the target identified, what are the tumor that you have identified the TU tumor? No? You have performed the quantitative analysis for the target tumors and qualitative analysis for the non-target tumors. Okay. And you also at week 4 you have identified the new lesions. Okay. Till here it is so basically till here it is a screening record. Sorry. Till here it's a screening record basically. Okay. So what are the tumors that you identify TU domain? You have performed the qualitative and quantitative analysis for the target non-target. At week 4 you have identified the new lesion. Okay. And also now these 22 was reduced to, for example, at 18, 15 got reduced to 10, 12 got reduced to 11, 18 got reduced to 12, 34 got reduced to 16. Now what is the sum of diameter? 67. Okay. Now seems like you were after give see why at week 4? At week 4 the patient, see, from screen the patient has taken treatment for 4 weeks. After 4 weeks, okay, the status was the non-tumor was absent here. Okay, the non-tumor was absent. Here it is also absent. Okay, right, and second. Okay, absent. Only that is only one non-target lesion was present. The remaining non-target lesion was absent. Okay, and the after that this whatever the for T01 the at screening was 22. Now it was reduced to 18 because they will perform again PET scan, all those things. Okay, they'll perform the PET scan. It was identified like this. Okay. And for this non-target, we'll keep it the group ID as non-target. Okay. Now, see what we have done. What are the tumor that we have identified the screening level, and for that we have performed the quantitative for the target, qualitative for the non-target. Okay. And at week 4, we have identified the new lesions. Along with that, we also performed the quantitative analysis for the target and qualitative analysis for the non-target. Now this is for week 4. Now let's replicate the same. Okay. New lesion, now let's keep it as no. No new lesion was identified. Okay. No new lesion was identified. And this is at which visit? Let's keep it as week 8. Okay. Let's keep it as week 8. Let's keep the weeks here as well for understanding. This is at week 8. Okay, week 8, right? Now this is for what? Now week 8. Now assume the 18 got reduced to 12. It got 10 got reduced to maybe 3. 11 got reduced to 6. 12 got reduced to 2. 16 got reduced to 11. Now the sum what? 34. Okay. Now let's keep this as upset. Now at week 8, what was the things? No new lesion was identified at week 8. Okay, the target tumor size was reduced to 34. The sum of target tumor reduced to 34, and all the non-target was upset. Will you agree with me? Right? Clear, everyone?
Yes, sir.
Right? Yeah. Now let's take this set again. Let's keep. This is at week 16. So at week 16.
What happened to that new lesion, sir? That is disappeared?
Yeah, it was not. No. That means it's no new lesion was appeared at this visit only. I'm talking, right? It's not like this lesion was disappeared. That's why I did not keep the link IDC. Okay. We are not going to further track the new lesion here. Okay. We are not going to further track the new lesion. Okay. Yeah. The question was, did you identify any new lesion at the week 8? Question was. No.
Apart from the earlier one. Okay.
We are not talking about earlier. The earlier lesion was identified at week 4 only. We are not going to talk about that, right? It was identified at week 4, and we are not going to track that new lesion in the further moving forward.
Okay, sir. Got it.
This is as per RECIST criteria. Now, did we identify any new lesion at week 16? Let's keep no. Okay. Now, the T01 got reduced to 0, T0 to 0, T03 0, this one 0, 0. Okay. And this becomes 0. Okay. This is for week 16. Now, let's copy this and paste another set at week 24. Let's keep it week 24. Maybe it's week 22. Okay. 20, right? Week 20, sorry. Okay. Week 20. Now, new lesion was, there is another new lesion was identified here. Now, the new lesion was new 01. New 01. New 01. So, new lesion was identified, but the target zoom was 0, non-target was completely absent. Okay. So, in this way, we have done the TR domain. So, basically, TR domain at every 4 weeks. Okay. As per the RECIST criteria, the tumor assessment should be done at every 4 weeks. So, at the every 4 weeks, the tumor was identified. So that all the target tumors which you have identified as screening and non-target tumors, no, for them you are going to perform the qualitative and quantitative analysis at every visit. See, if you see, we have performed the qualitative and quantitative analysis at every visit. Okay, and we also identify whether there is any new lesions has been there or not. Okay, again I'm saying we are not going to track the new lesion further. We just need to track whether any new lesion was identified or not. At week 8, no new lesion was identified. Okay, and at week 16, no new lesion was identified. At week 20, there is a new lesion was identified, and the other lesions also got tracked. That means the quantitative quality of the lesions has to be tracked. Okay. Now, what we are going to do is, so this is what we have done, right? Now, what we are going to do is, we are going to perform. So this is the TR domain. Okay, this is a TR domain. Now, RS domain. In order to calculate the RS domain, so we will do. So this is your TR domain. That's it. This will be your TR domain. Okay. So you have done the so what are the TR domain identified tumors? Those results have been captured in the TR domain. You are basically tracking the diameter of each tumor, the target and non-target tumor that you have identified at screening level, and you are also seeing that whether there is new lesion was identified or not. Okay. If a new lesion was identified, you have to give the link ID and keep it as S. If no, sorry, it's a new 02, right? Correct. Sorry, new 0 we have already kept. Okay, new 02. Okay. So if the new lesion was identified, no, so keep it as S. If the no new lesion was identified at the particular visit, no, keep it as no. Okay. So if there is no, just keep it as blank. Getting everyone is clear till here?
Yes, sir.
Right. Okay. Now we are going to talk about RS domain. So what is RS domain? Tumor
Response.
Okay. So please make down here we capture. Okay. Here we capture target response. Please note down non-target response. Okay. And overall response of each tumor. So here we capture the target response, non-target response, overall response of each tumor. Okay. So first, what is the formula for target response? Let's see. Let me save this. Target response. So we'll capture the target response, non-target response, and overall response of each tumor. Let it load. Okay. Now, first of all, for the target, first of all, in the target response are classified in different types. Okay. Can anyone tell me? Complete response. Please note down.
Partial response.
Partial
Response.
Partial response.
Stable.
Stable disease. Progressive.
We also have
Any,
not available.
any,
Not available.
Complete response, partial response, stable disease, progressive disease, not available. Okay. So now this is for now. When will be the complete response? So what is the, can anyone know what is the formula for complete response? See,
When all the
all the tumors
tumors are
disappeared and no more new tumors.
So just make this formula. Yeah, I agree with your point. Percentage change is minus 100. Please note down. Percentage change is minus 100% is complete response. Okay. Now partial response. Percentage change between minus 30 to minus 20%. Sorry. Minus 30% to minus 20%. This is partial response. Stable disease. Percentage change between minus 30% to plus 20%. Okay, this is stable disease. So this is a universal formula. Please note down. PD greater than equal to 20% increase from baseline is nothing but from baseline or nadir. This is PD. Okay. Now so now this is for a target response. So what is for non-target response? What are the different response for non-target? Non-target. Okay. So we have again same CR, non-CR, non-CR or non-PD. We have PD. Okay. PD. So these terms. Okay. And we also have not available. Okay. So non-CR, non-PR, non-CR or non-PD like this. Okay. These are the different target, non-target response. So what is CR? Again, in terms of here, disappearance of okay, see the spelling. Okay, disappearance of all non-target lesions. Next one is non-CR or non-PD. Okay, presence of one or more non-target lesions. Okay. Next PD. PD is progression of non-target lesions. Okay, progression of non-target lesions. Okay, so this is for target response, non-target response. We are going to calculate about orals. First, we'll calculate the target response. It's simple. Please note down the formula for the target response. Okay, please, this is the formula we're going to share. Okay, for target response formula. Sum of diameter at current visit minus base, okay, or nadir divided by base or nadir. Okay, so sum of diameter of current visit minus base or nadir divided by base or nadir into 100. Okay, into 100. This is the formula for the target response. Simple. Okay, first let's see what is the sum of diameter of current visits. Let's calculate the first. What we'll do is first we'll create the RS domain. Okay, so in the RS domain, what we have discussed, sub-GID, okay, RS test, sorry, RS test, RS ORRES visit. Okay, now first one, let's talk about 101 patient. Okay, see, in RS domain, response will be from post baseline. Please note down. Okay, in RS domain, responses, because we don't calculate response screening, right? Responses will be from post baseline visit. Okay, let's see. See, I don't write. See, and if you see, RS domain captures the target response, non-target response, oral response. First, what is the question here?
Target response.
Now, can we calculate target response now? Right? So, see the formula for target response. I already kept here. What is the formula? Diameter of current visit. Now, first, our visit is week 4. Assume that our visit is week 4. Okay. So, this is our visit. Okay. Okay. Now, let's see. For week 4, what is the sum of diameter? What is the sum of diameter? 34, right? 34 only, right? Sorry,
67.
67. Okay. So what is the formula here? 67 minus 1 divided by, what is the base value? 100, 101 into 100. Okay. So basically this is the formula for the week 4. Okay, I'm writing a formula here. Okay. So 67 minus 101 divided by 101 into 100. That is, see the formula, sum of diameter current visit minus base divided by base into 100. Okay, nadir will not be applicable, it will be applicable for that one. We say from moving forward for the next post baseline. Okay, so 67 minus 100 divided by 100 into 100. What is the value you got?
Minus 33.6.
Minus 33.6.
6.
Minus 33.6 percentage. See the where it is lying? Minus 33.
PR, partial response.
Right? Yeah. Partial response. Sorry.
So,
Here minus 32. It is, sorry, partial response minus 32.
SD.
9. Basically, you can keep it as 100. Okay, you can keep it as 100. That is nothing but less than 99.99. Okay, which is about 99.99 like that. Okay, so minus 3200. So which is, we call it as a HD, right? So it becomes HD here. Okay, now for this is the target response for week 4. What is the non-target response?
sir,
Yes.
if minus 33 lies between minus 32 minus
Yeah.
100.
Yes.
Minus 3200, right? Sorry, yeah, sorry, yeah. Okay, here minus 3200, so which is here. Okay, thank you. For non-target, what is the definition of non-target? disappearance of all non-target lesions. At week 4, do we have the disappearance of all non-target lesions? No, right? You have
One present.
one lesion. So we have discussed, right? Presence of one or more non-target lesions. So we call it as a what? Non-CR or non-CR. That means it's not a complete response, it's not a progression, basically. Okay. Okay, next. Do we have any new lesions?
Yes.
New lesions? At week 4 we have, yes, right? Right? So now
Yes.
1-0. What is the overall response? Because see, target response we got, non-target response we also there is a new lesions. Okay, what is the overall response?
PR.
Yeah.
Okay. Before doing this, what we'll do is we'll keep the table here. Okay. So we discussed about target, non-target, right? We discussed about the target response calculation here. We discussed about the non-target response calculation, right? Right. We did not discuss about overall response. So whatever in my mind, I'm just keeping here. Okay. I don't remember the exact coding, but whatever I remember, I'll just keep here. Target lesions, target response. Okay. Non-target response, new lesions, overall response. Okay. So let's calculate. This is a table. Okay. You can also find in the Google as well if you search the right document. Okay. So for target response, let's keep CR. Non-target is CR. New lesions is no. Okay. No means nothing. No effect. So overall response is CR. Target response is CR. Non-target response is PR. No new lesions, no identified. So oral response will be PR. Okay. Target response is PR. Non-target response is CR. No new lesion was identified. Oral response will be PR. Okay. So whatever I'm having in my mind, I'm just keeping. So just Google. If you have any document, you can just refer this document. Okay. Target response is SD. Non-target is CR. No new lesion was identified.
So do we have PR in non-target? Because in the above lines, it's CR, non-CR,
Yeah,
non-PD.
non-CR or PD, which is nothing. Yeah, non-CR is non-PD is nothing but your partial response. Okay.
Okay.
Okay. So SD, CR, this becomes SD, CR. Okay. CR, CR. Let's do one thing. Any, yes. Okay. Becomes PD. Why? Because no, any can be complete response or partial. Anything you can keep. Okay. Assume it's any. Let's assume you complete any response means any of this response. Here any means any of this response is there. But if new lesion is yes, no, that becomes a PD. That means in any means, for example, Asta will say any means I will assume it as CR. So now let's assume as per Asta, she is saying CR. Now Sujata says that any means she will assume it is a CR only. But new lesion is PD, it becomes new lesion is yes means it becomes a PD. Oral response. Because even the target is not is completely vanishing, the new lesion was appearing. So that becomes a PD. You're getting my point, right? So any means any response you can keep if you want. Any response you keep here. Your target is any response means CR, PR, SDR, PD. Your non-target is CR, non-CR, PD, anything. If the new lesion was identified, the overall response becomes PD. You're getting my point, everyone. Right?
Yes, sir.
Yes, sir.
Yeah. Next, CR, non-PR, PR, SD. Okay, SD is nothing but again non-CR or PD. No new lesions. That becomes SD. Okay. So this is target response. Okay. So I think some other examples did I forget? I'm not sure. Okay. If you want, you can. I'll send a document. You can refer. Okay. This is for target response, non-target response. Okay, now, so you have a target response, non-target response, overall response. Okay, now what is the overall response? Looking at the above table, CR, PR. Okay.
PD.
Oh, let's keep that one as well. Okay, we have some more. PR, yeah, anything is there, right? Anything. See,
Sir.
it can be PR,
PD.
it can be non-specific, that becomes a PD.
PD.
Progression.
Okay, this is for week 4. Okay, now let's calculate the same for week 8 as well. Okay, so for week 8, what is the target response? See, what is the formula for target response again for week 8, right? So week 8 we have 34. So 34, you should not calculate with the 100, calculate with the 67. Okay, 34 minus 67 divided by 67 into 100. What is the value you got? 34 minus 67 divided by 67 into 100.
49.25.
Minus 49.
Minus 49, right? So we got the value as minus 49 point, whatever may be, okay?
25.
25, okay? So which falls under what? PR, right?
PR.
Partial response. So partial response. And at week 8, what is the response of non-target? At week 8, absent, absent, absent. So this is what? CR, right? So PR, CR, no, do you have any new lesions? No, we don't have any new lesions, right? No new lesion was identified. So CR, PR.
PR.
So CR, which is non-CR, non-PD, which is nothing. So okay, PR, CR, right? This one, third one, no. So which becomes what?
PR.
PR. Okay. So next, let's copy this again. At week 8, let's keep for week 16. So for what happened for week 16? 0, right? That's a very good result. 0, absent, S at week 16, right? At week 16, do we have yes? No is there. Okay. So what is the response now? CR
CR.
for this. Okay. CR for this. Non-target CR. No, the overall response will be CR. This is for what? Week 16. Because completely target disease has been vanished, right? This is for week 16. Now let's do for the week. So did we miss week 12? Oh, unfortunately. Yeah, that's fine. Okay. You understand the concept, right? That's what. Okay. Next week 20 is there, right? We missed week 12. Okay, fine. No problem. Yeah. Let's keep week 20. So what is the CR? Same CR is there. CR is there, but new lesion was identified week 20, right? Now what becomes? Anyone?
Progressive.
PD. PD.
CR? No. We have yes, right? We have yes, which becomes PD, right?
PD.
PD. So for week 12, no assessment was performed. Maybe assume that patient has not come to the visit. Just assume 1, 2, 3, 4. Okay, let's keep here. So let's talk about these patients. Target response, non-target response at week 12, right? So let's talk about week 12. So week 12, basically no assessment was done for this patient, okay? So not available. So nothing was available. The patient was did not go any evaluation, right? So sorry. So At week 12 for this patient, the overall response will be what? Any. So not
Any.
any for this patient. Okay, maybe the patient has not come to particular usage, so it was not evaluated. Okay. So this is what your overall response. So we have calculated overall response is for target response, non-target response, and overall response will be there. Okay. So this is what we will do. Okay. Clear everyone for this HDTM part?
Yes, sir.
Okay. Let's take 5 minutes of break here. Okay. The call will be like this. So we will connect at 9:24. We'll connect at 9:30 once again. Okay. Hi everyone.
Hi, sir.
So everyone is available now?
Yes.
Yes.
Okay. So we have done with the TU, TR and RS. Okay. So now we are going to add up parts. Okay. I assume that you are clear with this TU, TR and RS. Okay. Now in the add-up part, we will be dealing with we will not have ADTU or ADTR. We are dealing with the ADRS. Okay. So in the now let's move to add-up part. Okay. So let's go to ADRS here. So will not take time. I think it half an hour we can close this. Okay, ADRS. So now in the RS domain, what did we create in the RS domain? Can you tell me? What?
Response, target, non-target, and
Yeah, target response, non-target response,
Overall response.
and overall response. Okay. Now in the ADRS, okay, in the ADRS, we are going to calculate two types of, okay. We are going to calculate best overall response, confirmed, sir. Let me keep, okay. Please note down. Confirmed best overall response. Another one is unconfirmed best overall response. Okay. Trust me, even people who are 8 years, 10 years experience, they don't know all these differences, logics. Okay. So understand this concept very clearly. Confirmed best overall response, unconfirmed best overall response. Okay. So best overall, see, best overall response is we are going to calculate. We are going to calculate best overall response. Okay. Best overall response. Okay. We got it as a BOR. I'm going to keep it as BOR. Is classified into two types. Okay. One is confirmed best overall response. Another one is what? Unconfirmed best overall response. Okay. Best overall response is classified three types. Two types: confirmed best overall response and unconfirmed best overall response. Now, coming to CBOR, right? Confirmed best overall response. This requires confirmation for CR or PR. I'll tell you what, okay? Whereas unconfirmed CB, unconfirmed CB or unconfirmed best overall response, okay? This do not require confirmation for CR or PR. Okay, so let's understand this by examples. Okay, now let's talk about it. Please understand that clearly. It will be a little confusing. Okay, now confirmed best overall response. So assume this: you are going to develop your ADRS from which domain? RS domain. You know, right? So from in RS domain. So I will just keep like this. So this is your RS domain. So you know RS domain what we'll do. So this is your overall response. Okay. Overall response. Okay. At week 4. At week 8. Okay. So now overall response at week 4. What is the overall response? Assume overall. See, from RS domain, you know what is overall response? We already calculated in which domain? In RS domain, right? We have already calculated the overall response in the RS here. If you see, we have already calculated the overall response at every visit. Every visit, based upon the target, non-target new lesions, we have calculated the overall response at every visit, right? Now you know what is this. Assume your overall response is CR. What does it mean? Can anyone tell me? What does it mean that? You have to give perfect answer. Overall response at week 4 is overall response of week 4 is CR. What does it mean that? Break, you all forget.
There is a
Complete
complete
response
response
for
and there is no
PDA.
lesion.
That means complete response for target lesions,
Target and
complete
non-target.
response for non-target lesion, no new lesion indicator, right? Which is coming from which domain? CR domain. Sorry, RS domain. Sorry, RS domain. Okay. But if you see the definition, this requires a confirmation for CR or PR. That means now if the patient is showing CR means the next assessment should also be CR. Getting my point? That means after 4 weeks, that means say from the screen to 4 weeks, after 4 weeks of treatment, the patient has shown CR. As if the patient has shown CR. After that, the patient will still participate in the trial, right? After 4 weeks of another treatment at week 8, he should show CR. Then only, now the patient has shown CR, right? Now what will you see? Week 4, week 8. At week 16, assume the patient has shown SD. You know what is SD again, right? It is again this SD based upon target, non-target, and a new lesion indicator. At week 20, assume the patient is shown PD, progressive. What do you know? What is progressive disease, right? This is basically what we have discussed. It is basically the increase in the size of the tumor. That means, for example, the patient at baseline is 101. The sum of diameter of all targets is 101. Now it was increased to 140, for example. Assume, okay, increased to 140. That means 140 minus 101 divided by 101 into 100. What was the percentage of increase? 37%. So now, did it meet PD or not? Right, 20% increase from the baseline, not which becomes PD. Okay. So in our example, we got CR, PR, SD, but we did not get PD. Okay. PD is nothing but the increase in the sum of the diameter. So from here, 101, 67, it was continuously decreasing. But if there is an increase in the tumor, no, 20% increase, no, from the nodule, no, or baseline, that becomes a PD. PD is nothing but the increase in the size of the tumors. Okay. Now at week 4, CR means what? Target, non-target has been completed CR, no new lesion. So CR. At week 8, target, non-target, complete response, no new. At SD means something either target, maybe based upon target. So the SD is coming based upon what? Target, non-target, new. Okay. PD is coming based upon target, non-target, new. Here also coming. Now, what is the confirmed best overall response for this patient? Can anyone tell me? Look at the definition. This requires the confirmation of CR. Why? See, the patient starting from screening. What is the best? What is the best? Best is what? What is the meaning of best? From the entire treatment of this is for 24 weeks. Okay. From the entire treatment of 24 weeks, what is the best response he has shown?
Yeah.
But did the patient got confirmed in the next visit? Confirmed, right? Because this requires confirmation. Confirmation means in the next assessment visit, the patient got confirmed. That's why the confirmed best overall response is CR. Getting my point? Okay. This is case 1. Assume this is the case 1. Okay.
So, sir, here, so from all the responses, we select the best one,
Best.
and then we confirm
Confirm
with the next one.
Next week, definitely. Next week it has to be confirmed. Okay. See, and
Okay.
what is the definition of confirmed? Again, I forgot to ask. Okay. What is the best overall response? Okay. Any response. What is the best overall response? Any response before PD. Please make note. Any response before PD. Okay. Okay. Any response before PD. Now let's see. Next scenario. Okay. Now case 2. Okay. Patient has shown CR. The patient has shown PR. Okay. NE. PR. Assume SD. Just for exams. Okay. Don't get confused. Okay. Now what is the best overall response? confirmed best overall result. What is a confirmed best overall response?
Here,
PR, because no, the gap between the next assessment is not applicable. It is up. That means any can be, see, this assessment to the next assessment, the any is applicable. That is fine. Okay. So the best for a confirmed best overall will be PR, because see, as now what Radha has told. So from this response, you have to select the best response here. Okay. See, and see what is the definition? Any response before PD. Before PD for this case 1. Okay. Assume 101 submit, what you submit, you assume. And this case 1, any response before PD means take these responses. After PD, you should not consider those response, because any response before PD, not to derive the best overall response, any response before PD. So from this, what is the best response? You have CR. CR to CR, you got confirmation. So CR. Now where is the PD here? We did not get any PD. So we can see the best response among that. Okay. Seems like this, there is a PR, any is between that. So any is applicable. Any can happen between these. Okay. Any can definitely happen between these. So that becomes PR. Okay, clear everyone till here?
Sir, so after PD, in case if we have CR also, we should not consider.
Not
right?
no. That's what. Any response before PD. Because why the reason?
Okay.
Because is PD is nothing but the disease got progressed. After getting disease progression, what is the benefit of getting CR? That's what the point, right?
Okay.
Right? Yeah.
Okay, and any is, we can consider it when we compare, right?
Yeah, any response before PD. Before PD. Any is nothing but something assessment was not done. So in the next PR means we assume that the patient is showing PR till long period of time. Like this. We assume, okay?
Oh, we are comparing this PR with the next PR.
Definitely. These PR with definitely. It's not with any with here. Definitely. The next is any, that means between the CR or PR. So now next see here. CR is there.
Sir, I just have one question.
Yeah.
So for case 2, week 4 PR, week 8 any, and let's say for week 16 we have CR, then do we select CR for the confirmed?
I'm going to come for the next example. That one, okay?
Okay, sir.
Yeah. PD. Now see, CR, we have a confirmation of CR. This becomes again CR.
Yeah.
Now let's see Radha case. What she is saying. So her question was, assume that we have PR, okay? So we have, let's take CR only. Why any? Let's take CR only here. Okay. Let's take PD. I will come to your case also, right? Okay. PD. Now any response before PD is PR to CR. See, PR to CR will become a PR only. Why? Because no, for CR it's a confirmation. For example, if you have CR here, that means you have a CR, you have a confirmation here. That becomes a CR here. You're getting my point. So PR, CR is there. No need to give priority to see from PR. What is the C? PR to CR, which becomes a PR. Okay, because why CR has not come? You did not confirm for CR, right? You're getting my point. If you're taking this as a best good response, for example, I will consider you rather consider this as a good response. Did you got confirmation to PR, CR? Now you say, sir, PR to CR is moving. I will keep it as CR. No, you cannot keep. Why? Because no, did you confirm CR to CR then? You did not confirm, right?
Okay, sir.
Right? So now PR to CR means you have to keep it as PR. Why? Because no, from it is not going, PR is not going to PR, but PR is going to more better CR, right? CR is better than PR. So you can keep it as PR. Now in this case, rather than PR to CR, you can keep CR to CR. So that becomes what? CR. Now,
Sir, you said CR is not confirmed, right? But CR is confirmed with the next CR.
see, the confirmation from PR to CR is also confirmed. Why? Because now, from good response to very good response, you are going, right? It's always not, it's not like always PR to PR. It's always, PR can also be checked with CR also, right? From good response to you are going to very good response, right? To be open.
Okay.
Right? Yeah. Now, PR. So your point was any and your point was CR. Now here it is PD. Now here it is PD. Okay. Here it is HD. Now becomes from PR to CR it was there, but CR you don't have confirmation. You have PD. So you have to check these points only, which becomes what? PR.
Yeah.
Here? Yeah. Now, okay, let's take case 6.
Sir, I don't get this, sir. We confirm PR with CR, so CR is more better, right? So why we are not taking CR
See,
here?
you are confirming PR to CR. You are not see. Where is CR again? You don't have CR here, right?
Oh, okay.
Right. What is your starting point? You are considering these two, this point, right? PR to CR. You are not taking the best of this, right? You are confirming from next assessment also it should be PR or CR. So from next assessment, if it is CR, no, then you want to keep it as CR, no, then see the next assessment. If it is CR, only just keep it as CR.
Okay.
Right?
Okay, got it.
Clear,
Got it.
everyone? Clear? See, any point you are see. Now Radha wants that she wants this as a point. PR to CR is moving. She want to keep it as CR. If you want to keep it as CR, confirm this point first. Leave this point, confirm this point with the next point. Okay? Now, PR, we can ignore. PR to next point is CR is there. Now, if you check next point is SD is there. So you cannot check the next point. So PR to CR, you are not taking the best of this. PR, you have a confirmed CR. So confirmed PR to CR becomes a PR only. So let me write a point here. Unconfirmed. What is unconfirmed? Basically, the starting point, the first point, the first assessment point we're taking. Whatever it can be week 4 or week 8, whatever it be, okay? Unconfirmed PR, okay? Unconfirmed PR to unconfirmed CR. What will be that? Unconfirmed PR to unconfirmed CR. What will be that?
PR.
PR.
PR, right? Next. Unconfirmed PR to unconfirmed CR. Let's keep unconfirmed CR to unconfirmed PR. What is the response?
PR.
Yeah, perfect. Okay. Next. Yeah, let me take example. Unconfirmed PR to unconfirmed CR, that becomes a PR. Next.
So are we taking the worst scenario in this one, sir? Because unconfirmed CR and we are confirming the CR with PR.
But CR has become PR, right? CR has become PR. So the overall response will be PR, right? CR has become, you cannot keep CR, right? How can you keep CR? The CR has become PR, right? Right? But we confirm the PR only. We confirm the PR, right? If the CR is coming to PR, no. So we are confirming the PR is confirmed. The very best overall response to best response. That is high response to somewhat better response. So can you keep CR here? You cannot keep, right? How can you keep? You did not confirm CR, right? So unconfirmed CR to PR. So let me keep not unconfirmed. Keep it as confirmed PR, right? Unconfirmed CR to PR. That becomes CR. So that becomes PR. Okay. Unconfirmed CR to what is that? Confirmed CR. So this becomes what?
Yes.
CR.
Okay. Next, unconfirmed PR to confirmed PR. That becomes what? PR. Okay. Next, see the case. CR. Okay. So you have a CR where you have SD here. Okay. SD, PD, PD, PD. Okay. See, you have a CR. From CR, the patient has moved to SD. Okay. Now, what will be the best overall response? Any assumptions?
SD.
SD.
SD. Okay. But in order to confirm SD, I'm writing here. Okay. In order to confirm SD, the gap between week, the gap between the week 8 to treatment start date should be minimum of 56 days. That means these assessment date, okay, week, basically week 8 assessment date, okay, assessment date minus treatment start date, that should be greater than 56 days only. Okay, you're getting my point? Greater than 56 days only. That means the gap. So if you see here, okay, should be 56 days. Getting my point, everyone? So in order to confirm HD, so you are 56 days. See, for example, what is happening here? Your CR is not getting confirmed. Will you agree with me? Your CR is not getting confirmed, right? Okay, you got HD here. Assume your CR is not confirmed here. Okay, now you got HD here. How you are keeping HD? Anyone? How you are keeping? So you got a response here, HD, which is not PD here. This assessment date minus treatment start date should be, that means 56 days should be. So in order to confirm the HD, the gap between the VK to treatment started should be minimum 56 days. That means the assessment date to the treatment started. That means why 56 days? That means if the patient within the 56 days, if he has showing the response as HD, the best overall response will be HD. You're getting my point? That means in order to confirm HD, the response date minus treatment start date should be at least 56 days. Clear, everyone? Any confusions? Right? See, CR to SD, did you confirm your CR? You did not confirm CR, right? So now move to next point. All these are PDs. You cannot this, right? You cannot confirm. Now, these date minus treatment started, you have to check. If it is 56 days only, you have to keep it as SD, right? You have to keep it as
Sir?
SD. Yeah.
So you said the gap between week 8 to treatment start date. So week 8, if we count, it's always 56, right? Because we
Sometimes the patient undergo assessment early, which comes 53 days, 52 days, right? You getting my point? Sometimes the patient undergoes early, so assume the patient has come to 52 days early, right? It becomes 54 days. Now, can you keep it as HD? No, right? So here, you're getting my point, Radhika? Radha.
no, sir, I didn't get.
See, you are saying that at week 8, basically the patient will come 8, 7, 56, you are saying, right?
Yes.
But now from today's date, if you calculate 56 day, okay, today's treatment start date. Assume the 56 day is something like 16th, but the patient came 3 days early. Okay.
Oh, so if the patient started treatment 3 days early, then okay.
Assessment for week 8 assessment, he came 3 days early. Right?
Okay.
Yeah.
Got it.
Here the gap is 56 days. Okay. Now,
So, sir,
yeah, come. Tell me. Yes.
is it always the first treatment or it can be the second or third treatment? So we'll go with the latest treatment.
No, first the patient, the first or that first. No, say you have to take the first treatment from the start of first treatment. Okay.
Okay.
Yeah.
And can we have, if it is a first treatment in week 4, will it be possible that they also have treatment at week 8 or like in between?
The patient start treatment at week 0, okay, which is day 1. Okay, at week 4, if the treatment, we will not tag the response. If you are taking response from week 0 to week 4, week 4 to week 8, like that we are doing. Okay, so you're getting my point, right? So I mean to say that the patient will not take the like this, okay,
Treatment in between week 4 and week 8.
Yeah, we will still take the week 0 treatment, the first treatment from the start of first treatment.
Okay. So is there a possibility that he can take treatment in between week 4 and week 8?
Yeah, see, for example, the patient has taken week 0. Okay, assume the patient is this is nothing but your TRT SDT, the treatment start date. Assume, okay, the patient takes the treatment and comes after 4 weeks to the week 4. In the week 4, he will go with the assessment responses. Okay, that means the TR, RS, everything will be calculated. Okay, now At week 4, the patient has shown complete response. At week 4, again he will take chemotherapy. I will come for
Okay.
again for 4 weeks. Again,
Okay.
assessment was done like that. Okay.
But we are still considering the week 0 date here.
Yeah, week 0 because the first treatment we have to do. Okay.
Okay. Okay.
Now here, the gap is 52 days.
56.
52 days. As in the second case, case 7. Here it is 56 days. That's why we are keeping as HD. Assume the gap is 52 days. Now what happened? This CR is not confirmed. Did you confirm HD? For HD confirmation is what? 56 days. See, for CR/PR, you need from CR to PR, PR to CR. You're doing some confirmation. But for SD, you don't need to check for the next visit. Okay, you only check for this date to what we say the treatment start date, right? Now assume it was 52 days. Now what was the best overall response for this patient? You cannot keep CR, you cannot keep HD. PD is the best.
PD.
Okay, yeah. Now case 8. In the case 8, the patient has shown CR, PD, SD, PD, something like this. Okay, assume. Now the gap between these two visits, okay. In case 8, the gap between, okay, the gap between week 4 to week 8 is not 28 days. You get my point, okay? In case 8, the gap between the week 4 and week 8 is not 28 days, okay? But the gap between, okay, week 8 to TRT SDT is greater than equal to 56 days. Looking at this point, can one tell me? So for confirmation, definitely 4 weeks of gap should be there. Definitely, at least 20. Not should not be at least the 28 days means 4 weeks means 28 days should be gap. This should be there. You're getting my point. The gap between these to this, the 28 days it should be there. But here in the week 8, there is no 28 days gap before the week 8. So can you confirm CR? No, right?
No.
But the gap between the week 8 to the treatment start date is 56 days. So
So it's
that's
SD.
SD, right? SD is always not like the SD response should be always checked with the treatment start date. The unconfirmed CR or PR, if the CR is not unconfirmed, no, it's not confirmed, no. So the second point can also be checked with that. Getting my point, everyone? Okay. Now in the case 9, the
So
patient got,
now,
Sir,
yeah.
so if for line 31, it doesn't apply to case 1 then, because there is no
We have
28
confirmed, right?
days.
We have confirmed gap of 28 days, 4 to 4 weeks. Agree my point. So for confirmation, I told, right, at least 4 weeks of gap should be there. So you have 4 weeks gap, but especially in case 8, the gap between these assessment gaps is not 4 weeks. Okay, it seems to be week 4, week 8. It's something like 26 days is there.
so
Yeah.
since it's satisfying the 56 days, we are considering as SD, or we are taking the last week 20 as SD.
No,
I mean the line case 8.
first we are checking for CR. Did we confirm for CR as per my point below? No. For confirmation of CR, PR, anything, at least 4 weeks of gap. That means this is the unconfirmed, this is a confirmed to be open, right? Because we have 4 weeks of gap. But in the case 8, we have 4 weeks of gap, but I'm writing a point here. Note, in case of week 8, the gap between the CR to CR, we don't have 4 weeks of gap. We don't have 4 weeks of gap. Okay. Now, can you confirm CR? You cannot confirm CR. Now, what is your next point? You cannot confirm PR also, because CR to CR, if you want to CR, it is not CR to PR or PR to CR. Okay. The point is the gap is not 4 weeks. So you cannot confirm CR or PR. The next point is you have to check for HD. How you are going to check for HD? These date, first you check these date with the treatment start date. It is not possible, right? For 4 weeks, it is not possible to 56 days. It will not come. Then you will check whether these assessment date with the treatment start date. You have 56 days. Then you can keep it as HD. Clear?
Yes, sir.
So,
Right.
sir, for case 8, we are just assuming that there is no gap of 28 days.
Yeah, just for your
We are
understanding. Because
okay,
if I
okay,
don't write
okay.
this point, no, you just confirm why not it is CR. If I don't write this point,
Okay, got
right?
it, sir.
Now PR to PR, again same case. What will this is? Again HD. Because in case 9 also I'm writing. In case 9, the gap between the gap between the week 4 and week 8 is not 20 days. So the gap between the week 8 to treatment start is 56 days. So you can also check with PR to treatment start date. Okay. These but it's not possible, right? Week 4 is basically 28, 29 days will be, right? So it's not possible to get 56 days of gap. So for SD, you don't require confirmation. Okay, to give SD, that particular visit assessment date minus treatment date should be greater than 6 days. That's it. Okay. Clear, everyone? Clear, right?
Yes.
Yes, sir.
Case 9. PD, CR, CR, CR. What is the best overall response?
Yeah.
PD. Because what is my
Okay.
definition? Any response before PD. Any response, right? You are not the after the reason, because once the patient has is increased the disease, no, PD is nothing but the disease has been worsened. Once the patient disease has worsened, no, so basically it becomes very weak. Then what is the showing? What is the need of showing complete response? So any response before PD becomes PD. Okay, case 10. Next, case 11. SD, PD, CR, SD, CR. Can anyone tell me what is the best response? Confirmed best overall response?
PD. PD.
PD. Why? Because no, first there is a possibility of SD. Why? Because no, these SD assessment dates should be checked with the treatment start date. If it is greater than or equal to 56 days, no, that is fine. But it is not possible, right? So that becomes a PD. You're getting my point, right? So this is what the confirmed best overall response. Now what we will go with is a unconfirmed best overall response, which is U CBOR. Okay, for the same thing you will go. So for this, I don't need any confirmation. It's very easy. Can one tell me? Case 1, CR, right? No confirmation is required. For this,
Yeah.
PR,
Yeah.
CR. For 4
Here
case
we are
4,
just here we are just choosing the best out of all the results.
best response before PD, again before PD. Okay. So CR, PR, CR. You have CR before PD, right? In this case, where PD happened, in this CR is the best response. So we'll keep CR. So okay. So in this case, anyone?
CR.
Okay, good. CR. Here.
CR.
Yeah.
CR.
Right. This is
PR.
PR. So we have PD only because any response before. Okay. Here SD.
SD.
Okay. This is what for the unconfirmed best overall response. Okay. Now so we are done with the confirmed best overall response, unconfirmed best overall response. Now we are going to calculate the third case is confirmed objective response. Okay. So objective response is nothing but patients whose confirmed best oral response is CR or PR. Getting my point? Confirmed objective is one of the endpoint here. Okay, confirmed objective response is there, but patients whose confirmed best oral response is CR or PR. Okay. Now can anyone tell me? Now we have 12 cases. Case 12. Assume these 12 cases are what? 12 cases are what? 12 patients. Okay. Assume these 12 cases are 12 patients. Okay, I'm just writing 101. Okay, 102, 0. Assume these 12 cases to 12 patients. Let's assume the different 12 patients like that. Okay, 109, 110. These 11 patients we have, right? 11, 11. Okay, 11 patients. So you have confirmed CBOR, confirmed best overall response, unconfirmed best overall. Okay, let's keep all these things same way. Okay, right? What is our definition? Confirmed objective response, patients whose confirmed BO best overall response, can see confirmed best overall is CRPR. Now, confirmed objective response. Can anyone tell me? Okay, so this patient, what is the for this patient? What is the see patients whose confirmed best overall is CRPR? Now, this patient best overall confirmed best overall is CR, right? So I will keep it as S, right? PR. So I'll keep it as S. Yes, S. PR. S. SD. No. Right? PD. No. HD. No. Again SD. No. PD. No. Right? Getting my point? PD. No. That means patient who has achieved the confirmed best overall response as CR or PR. No. I will keep it as S. Otherwise, I'll keep it as no. Getting my point, everyone? Confirmed. It is basically
sir.
patients who confirmed the best overall CR or PR. Okay. Now, unconfirmed objective response. You can write, you can easily tell the definition. So unconfirmed is what? Unconfirmed objective response patients whose best overall, not confirmed, best overall response. Okay, whose unconfirmed best overall response is CRR-PR. Right? Now what is this? Unconfirmed objective response. Okay. So one now based upon this. So S. So basically S for till here, right? Till H S. This is again yes only, right?
No.
No. No. Okay. Next. So we have done with the total 4 points. Next. Confirmed clinical benefit. Benefit spelling correct, right? Benefit. Confirmed clinical benefit. Okay. What is the definition for this? Okay. Right. Next. Patients with confirmed best overall response. Best overall response is CR, PR, and SD. Okay. CR, PR, and SD. Now can we write? Can we calculate here? What is that? Clinical benefit rate, right? Confirmed clinical benefit. Okay. Confirmed clinical benefit. Now what will say? Patient who's confirmed based on CR, PR, SD. So basically we can keep S. Yes. Based upon this point. Okay. S. Okay.
PD.
PD. No, right. No. Okay. Now. So this is basically PD. No, right? Next. So once you confirm, you get this down, everything is very easy. Okay. Next is what? Unconfirmed clinical benefit rate. Whose unconfirmed best overall response is CRPR SD. Now what, based upon what? Based upon this one, okay? Unconfirmed clinical benefit. So based upon this, seems like everyone except this patient, right? So S, let's keep S for everyone. Okay. Yeah, that's it. About hard ADRS. Yeah, I don't think many things are okay. Total. Next one is duration of this. Let me think. I'm just thinking on that. This is control. What else is there? Informed best response. Okay, I think so. We are done. Right. Now, okay, let's take 10 more minutes. Okay, now from what we are going to do this. Okay, from this, what we are exactly we are going to do this. Okay. Now, table 1. Okay, table 1. You can tell all this in summary of confirmed best overall response. Now, assume there is a treatment called drug A, which is your chemotherapy. Okay, let's just take another. Okay, let's compare with placebo. Okay. Next, so best response. What are the best response? CR, PR, SD, PD, NE. Okay. Okay. Now looking at the above table. Okay. Just assume. Okay. Best overall response. So your capital N is nothing. Basically, we have assume like we have capital N is for example 20 subjects here. Okay. In placebo also we have capital N equal to 20 subjects here. Okay. Now how many patients are here? Confirm. See what is my title? Summary of confirmed best overall response. How many patients we have? 1, 2, 3. 3 patients, right? 3. How many are PR? 1, 2, 2 patients. How many are SD? PR 2 patients. SD 1, 2, 3. 3. What is how many are PD? 1, 2, 3. 3, right? Total 3. So 3 plus 6, 7, 8, 9, 10, 11 total. Okay. Just assume. Okay. Just assume. Okay. Any maybe something like you can keep. Okay. You're getting my point. Based upon this, looking at this ADRS, this is an ADRS domain. Okay. Looking at this, that we have done the percentage. What is the percentage? Okay. Just assume. Okay. Let me keep it as 15 subjects here. Okay. Here also let me keep it as 15 subjects. Maybe remaining subjects are not available. Just assume. Okay. Now what is the percentages? 3 divided by 15. What is the percent? Can you tell me? Just look at the calculator and just tell me what is the 3? 3 divided by
20%.
20%.
20%. And for 2, 15%.
13.3.
13.3%. And for 3 also again
20.
20%.
percentage. Okay. And 3 also same 20% like this. Okay, the same we'll also do for drug. And we'll compare how the patients are taking drug. Patients are taking drug A, how much patients are shown the CR. Okay, seems like they have shown 1% here. Where no 0% says CR, PR as 0, maybe SD as something like 11 people, PD 3 people. Okay, one is any like that. So seems like our drug is not showing very, most of the patients who taken our drug, you know, as anti-cancer drug, they have shown very good CR or PR. So the percentage of patients who are showing now, what is the objective response rate? See, continue the table. I'm just continuing the table. There is no difference. Okay, continue the. I'm just continuing the table. Okay, confirmed objective response rate. What is it? Yeah. Confirmed objective response rate. What is that? Can you tell me what is the confirmed objective response? What is the definition? See here.
Patients would
Confirm
confirm best
PR.
overall
PR
response
or
is
PR.
CR or PR.
Now, how many patients were there? Here, 5 patients.
5.
Here, 0. So from that, 5 means how? What is the percentage? 33.3%. Right. So that means the patients who are taking our drug, 33% of the patients are showing their benefit as CR or PR. Getting my point, right? Like this. Summary of confirmed best overall response rate, like this. Okay. Clear, everyone? So you can also do the summary of unconfirmed. Okay, you can just assume, based on that, you just assume and you can calculate table number 2. Okay, summary of unconfirmed best overall response. You can do the same table, but looking at the column number 2. Clear, everyone? Okay.
Yes, sir.
So what is the primary objective of oncology trial? To determine the
Overall survival.
Overall
to
response
determine
rate.
the overall survival. PFS we already discussed in the timetable.
Progression-free survival.
Progression-free survival. Okay. Next one is to determine the best overall response. Okay. And determine what? To determine the rather than confirm, you can just keep the best overall response, and also to determine the objective response rate. Okay, you can see these endpoints. Objective response rate. Okay. Another one is clinical benefit rate, right? So remember the clinical benefit rate. Okay. We also call it as a disease control rate. Please note down disease control rate. We also call it as disease control rate. Okay. They call it different terms. Don't remember this. Clear, everyone? So here finish the oncology part and our last class also. Okay. Any questions? I will send this video in Excel sheet and you can just save with you. Okay.
Sir, where for the ADRS, which guideline or IG do we refer?
We don't have any IG for this, actually, to be open. That's what, right? But the reason, because no, the reason why do we don't have it is we have different guidelines, right? See, I told, right, RECIST criteria. For all these criteria, they cannot develop the IG, right? It's very difficult for the CDs to develop the guidelines for the IG for all this based on, say, RECIST has their own guidelines. That's why we don't have IG. Okay. So go to Google and search for the RECIST document, RECIST one document. You will get a lot of documents. Okay. They'll show the same, these type of examples. Okay.
Okay, and for TU, TR, and RS, it's the same as DTM, IG.
Yes, SGTM. You can just download, search SGTM tumor domains IG. You search with this term, SGTM tumor domains IG. Okay. You will get one Excel sheet also, and also one PDF file. You can just use that templates, those documents.
Okay, sir.
Okay, then any questions? Okay, then. So have a well prepared. Sorry.
Just one doubt, sir. In confirmed response, the fourth case, I think.
Yeah.
Just want to need it. So we are just checking the PR with CR. So it's not confirmed. So we are leaving the PR and confirming the CR with the next CR and taking the CR.
See, first we are checking the PR with CR. Okay. but there is a point that CR and CR is also there. Will you check these 2 points or will you check these 2 points? Basically, definitely these 2 points, right? You're getting my point. See, which is the best response among that, among all these points? CR. So definitely what you will check, whether the next point is also CR or not. If it is CR, no, you will check whether between these 2 gaps 4 weeks are there or not, at least 28 days gap. If it is there, you will confirm it as CR. But if it is not 28 days gap, no, then you will come backside again, you will check with this PR with CR. If it is 28 days gap, no, then you will confirm PR. But here already, see, you will ignore the PR. The reason, because you have a 2 best points here. Why you should focus on CR, PR, right? So you have 2 points here. You check the CR to CR 28 days gap, then you will keep it as CR. If it is not 28 days gap, or if the next subsequent point is not CR or something like SD, then you have to focus on this. Clear?
So in that case, we'll which one we'll choose? If it is PD here, we'll choose PR.
I did not get this.
No. If the week 16 is SD and the first one is PR, so
you have to check these 2
in
points. You have to check these 2 points, right?
okay, then which one will choose, sir?
PR.
Which one will be
PR, right? PR,
PR, right?
Yeah,
okay.
Yeah, see, that's what, right? PR to unconfirmed. See, PR, where is it? PR to unconfirmed CR becomes PR only. Unconfirmed PR to unconfirmed CR, which becomes PR only. Okay.
So the unconfirmed CR is the date which is lesser than the mentioned date.
See, this here is not confirmed to the next point. For next point, it was not confirmed.
Next point. Okay.
Yeah.
Okay. Got it. Sir. Thank you.
Okay, then everyone. So all the best for your interviews. I think my trainings are helpful for you. So you will definitely get job. Please do hard work. Okay. So go with the videos again and again. Okay. Maybe don't get fed up that definitely this is very big concept. Clinical is very big concept, but definitely there are very good packages. Okay. All the best, everyone.
Thank you, sir.
Thank you, sir.
Thank you so much.
Thank you, sir.
Yeah.
You had more patience in explaining all our doubts. Thank you so much for that.
Yeah, no problem. Yeah. So if you have any doubts, you can reach out to me in WhatsApp, but maybe till the next November 17th, I will be very busy with the work. So I will just try to respond if I have a time. Okay. And do mention if you get job, please mention me in WhatsApp. Okay. I will be more happy.
Sure, sir.
Yeah. Thanks, everyone. Thank you.
Thank you, sir.
Thank you,
sir.
sir.
Thank you.
Bye.
Thank you so much, sir. Thank you.
Thank you. Bye.